Hello, and welcome to the OR Manager Conference Encore virtual event. I'm Carrie Shapiro with OR Manager, and I'm pleased to welcome you here for our session, Navigating the Pandemic and Its Financial Impact on Healthcare. Today's session will be moderated by Sherry Church, Perioperative Services Transitional Leader with HCA Healthcare. As you listen to the session today, we encourage you to submit your questions throughout in the Q&A chat section on your screen. At the end, the panelists will come on live to join the moderator and participate in live audience discussion. Now, please join me for watching the session, Navigating the Pandemic and Its Impact on Healthcare.
Good morning, everyone. It is 10 o'clock on the button. Should we wait or should we go for this on-time start? On-time start. You know, when I entered nursing in 1976, and yes, I know some of you weren't born then, but in 1976, guess what we were talking about? On-time starts, but I digress. Anyway, my name is Sherry Church. Good morning. I am the moderator of this unbelievable panel. Many of I've just met myself, but these are really leaders in the industry from all around the United States. I myself am from South Carolina, Charleston, South Carolina, the most beautiful city in America, if you ever want a vacation there. And why don't we go ahead and introduce yourself? Start with you, Beth.
Good morning, everyone. I'm Beth Bozelli. I'm from Nashville, Tennessee. I work for HCA Healthcare as the AVP of Surgical Services.
Good morning. My name is Janet David Lastina. I work at University Medical Center in Las Vegas, Nevada. I've been a director for too long.
My name is Vikram Tiwari. I go by Vic. I'm also from Nashville, but from Vanderbilt University Medical Center. I am a faculty in anesthesia department, but I'm not a medical professional. I'm a researcher in operations management.
We won't hold that against you.
Well, my mom wanted me to be a doctor, so I keep telling her I'm a faculty in medical school. I have a PhD. I can write doctor. Again, this is as good as it's going to get for you. But I work in the perioperative analytics and also other analytics for the hospital.
Good morning. My name is Alyssa Arisi. I work with LeanTOS. I'm our Director of Implementation. We have a software product that helps operating rooms with capacity management. Work very closely with Cindy from Mount Sinai. Nice to meet you all.
And I'm Cindy Gordesky. I'm the Vice President of Periop Services for Mount Sinai in Manhattan, New York for downtown.
So you can see we're from all over the United States, which I suspect most of you all. Do we have any Chicagoans here? Oh, there we go, a couple, three Chicago people here. Well, you have a beautiful city, but I suspect it's gonna snow any second, right? I mean, it's so cold. Us from the South, there's like, I brought my flip-flops and I don't know what's going on here. Okay. We're gonna talk about what we want this opportunity for you to ask us questions. We're gonna tell you about our experiences, how we coped with COVID, some of the financial impacts of that, which quite frankly, in my own estimation, I don't think we'll ever really know. I think it's gonna be one of those things that we try to get our arms around for years to come, and we're never gonna really know what the final dollar amount when you talk about redeployment, staffing, et cetera, and loss of or missed opportunities of surgical cases, whatever. But before we get started, one of the silver linings of COVID, and yes, there were silver linings. I'll give you a personal one. My sisters and I, who are spread from coast to coast, I have 4 sisters, we Zoom and continue to Zoom every Sunday now. And we never did that. So that we've always been close, but that was kind of a cool silver lining of COVID, and we're still doing it last Sunday, and I got one this Sunday. So there you go. But some of the funny things that came out, and just yesterday, I saw this study, seriously, just yesterday I saw this, memes about COVID-19 helped us cope with life in the pandemic. There's a study that's going to be published in Psychology of Popular Media. And again, this literally was on my news clips yesterday. So I thought I'd go ahead and bring up a few of the memes because I don't know about you guys, but some of these were like hysterical. And we used to post some of these in the OR. Like I would find some of the funnier ones and post them in the OR. Like that's a typical nurse schedule, reality versus fantasy. I love that. Work, off, work, on call, off, work, work. When I get bored, I call in sick to places I don't work. Tomorrow I'm getting written up at Walmart. I love that one. This is kind of long, but the cats are on 3,700. Oh, wait, I won't even read it to you. That's a long one. Just take a nap afterwards. That's the key on that one. Quarantine coffee, did anybody have this experience? No coffee, but a lot of margarita. If 2020 was a drink, what would it be? Colonoscopy prep. Dear July, no trouble, please. Just take a seat. If the dinosaurs are, these are all memes. Probably you saw them on Facebook, and there's thousands more. I love this one though. Toughest and least recognition, thanks Steve ES.
Yeah.
Couldn't have done it without him. That actually looks like me with the short hair, but I did never succumb. Thank goodness my hairstylist still stayed open, and we all wore masks, but he saw one person at a time, but it did work, so that was great. If 2020 was an ice cream truck, liver and onions, so they'd be selling. And that's so appropriate to us. Wear a mask, that is, unless you want to be intubated by a gynecology intern. July 1st, you did our last semester on Zoom. Yeah, that is so true. That's so true. And the Joint Commission's plan to battle COVID-19. Not sure. There was one I saw, but I couldn't find it again. It said, last week we were worried about tape on the wall with Joint Commission, and now we're using a sock for a mask. So, whoops, did I go? I don't know what I'm going to wear to the living room New Year's Eve. I might not even go. Waiting, that looks like my husband, kinda. Waiting for his wife to get home from work with the spray. No, change in the garage. Don't come in here. Don't come in here. Nurse life, that's me every day. Breakfast, lunch, dinner, 82,000 calories. The nurse's station, remember how you can't even have a cup of water at the nurse's station? Well, they're all out grilling there. Breakfast is going on. And so on and so forth. But there's just so many great memes and very, very, very funny. Yeah, those are my grandkids actually, like that. This is near to all our hearts. Virtual meetings are modern seances. You there? I can't hear you. Can you hear me? And you know, I've come to hate
You're
webinars.
muted.
I'm sorry, I'm just.
You're muted. Well, please mute yourself.
What's that? What was that?
Mute.
Mute yourself.
Please
Oh,
mute yourself.
Yeah, I love it when you hear the dogs barking in the background and all that stuff. And then this is the most important. Never regret a day in your life. Good days give happiness. Bad days give experience. Worst days give lessons, and the best days give memories. And that's certainly true. And the last couple of days have certainly been good days here. So those are memories we can take with us. With all that said, who would like to talk about their COVID experience on the panel? We can start and say what happened to you when Beth, what happened to you when you heard about COVID?
Well, I never expected it to get to how it got. And I'm at the corporate setting, so hats off to all of you that are in the ORs and at the facilities every day. And in my role is to support our facilities, and I work for a large corporation, and we have a lot of hospitals across the U.S. And so our role was really to see how can we support our peers in the field. And we were fortunate enough to be able to move nurses from Colorado to Texas. And then we have some strong, and I know Vic, you can talk about this, but we have some really strong analytical minds in our organization where we were able to see where do we need to move people, what is kind of our case backlog. But I know going forward, one of our biggest problems that we still see is our staffing. And it's not only our staffing in the OR, but after this pandemic hit and we had nurses on the units that left and went to travel agencies, we are now having issues to be able to do cases, because when we try to take a patient to the floor, we don't have nurses on the floor to take those patients on the unit. So our biggest thing with our organization has been to really, how can we support the field, what does it need, and how can we use the resources that we have to distribute them to be able to help our patients.
Is that a problem for anyone in the room? Having a place for the patient to go, like a med-surg bed or an ICU bed? Yeah. And where are you from, ma'am? I'm from Minnesota. So is surgery still questionable if there's not a post-op bed? Okay. Wow. Even still here in almost the end of 2021. And that's Minnesota? Yeah, Minnesota. Got it. I'm sorry, you were going to
Yeah.
say, Vic?
Yeah, so I'm going to just piggyback on what Beth was saying. And initially, my experience as an analytics person was I was watching all of the things happening and planning occurring. And I was thinking maybe this is when we probably don't need too much analytics because we are likely shutting down the ORs. And then it came like out of nowhere. And the first question, of course, for us was, how many ORs should we retain for our normal business and how many should be converted to ICUs? So out of nowhere, we were drawing plans on figuring out which ORs essentially do elective surgeries. And then we learned there is nothing called elective surgery really. And that was an eye-opener because everybody in the city was obviously talking about shut down elective cases. So anyway, so long story short, we made our plans. The first surge never occurred in Nashville. So everything just dropped off and there was crickets essentially, right? So, but the plans were set. All the analysis essentially led to how many ICU beds should be reserved for normal business, how many floor beds should be reserved for normal business. But then it actually ended up being used during the summer and more so during what happened in winter. But by that time, everybody was so tired, at least here in our south, probably in Nashville area, that the normal business never really stopped. And so that's when we started realizing the difficulty with this pandemic and the planning, that plans are basically, I think, following what is actually happening. So we are always trying to play catch up. This shortage of our nursing that now we are seeing, right? So this wasn't anticipated. And this Delta surge, we had to shut down our surgical cases, our ORs, not because there weren't cases, but because we needed nursing in the floor units and in ICUs. So our anesthesiologists, our nursing people, they are being transferred into those places to work in those what we call pop-up ICUs. And so I think we are still chasing this phenomena. I was hoping to say that we are past this, but I don't think maybe there is something else that might come up 3 months later when we all realize that our immunity has waned off and not enough people have taken boosters. I don't know. This is being, it's moving.
So you're an optimist, okay.
Right.
So you're an optimist. I can tell you, as I have to stand up. I'm sorry, guys, I can't see these people, and it feels so rude not to see you. I've been around as I told you, 44 years in the OR, and our first battle, we were talking about this in the hallway, was, and I know your younger people will think this is crazy, but it was hepatitis. We didn't know anything about hepatitis. We used to pick up bloody sponges in our hands, and then along came SARS, and along came the bird flu, and eventually AIDS, and we all thought we were all going to die because if we had a patient that might have AIDS. So I think COVID, at least I was working in an operating room at the time, and I do consultative work in my company too, now in Savannah, Georgia, and we were panicked because it was respiratory, so we really didn't, even though we were used to the full-on striker suits and hoods, and we said, oh, we got plenty of that stuff in the back, but we didn't understand, is this like TB? Are we gonna get the droplets on our faces and that kind of thing? How many of you immediately shut down your ORs when you heard? You did? Tell us about that.
I'm in New Jersey,
Oh.
so we were part of the beginning of the pandemic, and it was really like a light switch. I remember it was like March 13th, everything was still fully operational, going into the weekend,
Oh, wow.
and I had my phone. So Friday, we were like, wow, okay, so we have now 10 cases in the hospital at that point, so 10 positives. And when I was leaving Friday at 5 o'clock, we had 60 pending cases, 60 pending patient results that were in the ED. So we were still like, okay, this could be fine. They're not all going to be boarded in-house. Saturday morning, we had 30 more patients show up. All 30 ended up needing med-surg
Wow.
Sunday, we had another 50. So out of the 50, I think 45 ended up coming up. And then from the 30 that were here on Saturday, 15 went into our ICU. And Monday morning, it was like 5 a.m. All cases, we were calling patients and canceling all the patients for that day. We were in like a huge surge at that point. So we went from, we were a 450 bed hospital. Out of that, on that Monday morning, we had 120 some odd COVID patients in-house, but we still had our 300 patients that were already here from that Friday. So we were really slammed. So it was like all hands on deck. We floated all of our nurses. All elective cases stopped that Monday, and we and by elective I mean like all surgery. Unless you were a perf foul, unless you were imminently going to die, nothing was going through. We didn't pick up our surgery.
Did you treat everybody as positive? Because we didn't have tests, right? We didn't have the rapid test for sure, and even the lab test was overnight.
In the beginning, so I think there was a preamble to it that people were coming in, and we had that long testing period.
Right.
So if their symptoms were not unmanageable, they went home. And what we found was that the 2 weeks prior, there was people that were coming in and getting tests, and then we would find out 5 days later that they were positive, and we didn't hold them here. They decompensated and came back.
Yeah.
And it was those same people that returned that weekend, and then a large majority of them were housed in our hospital, and then a larger majority of them became critical and were there for 40 days plus or expired.
Wow. Well, Cindy here is from New York, so she probably was sending New Jersey those patients. So, Cindy, what happened in your?
Yes.
That we had. So we're on the rail line, so the people who in the city couldn't get care
Yeah.
Kept going.
the trains and took them off of, I remember holding up a map, and that was part of the data analytics that we did. So when we first got cases in New Jersey, it was very, very small, and it was very like, New York is handling it, New York's got it all. And then all of a sudden there were these pockets in New Jersey that were happening. And as someone who takes the train all the time, I'm familiar with the way that things were going, and it was like the Morris County train line was, you could see the pockets in the hospitals all the way through.
Interesting.
So we realized that it was the people who couldn't get care in Mount Sinai or Presbyterian who were then traveling back into New Jersey to get the care, because it was like mixed.
Well, let me ask you, Cindy, since you're director of how many ORs?
50.
50. Well, yeah, so part-time. Okay.
Yeah.
How did you keep track of what was canceled?
Yeah, so we have the fortunate benefit of having 2 separate hospitals with 2 different EMRs, so it just made things so much harder. But I think one of the things that we struggled with was, as you can remember, the rules around PPE, right? You can wear that N95 for a day. No, you can wear it for 12 days. Well, you can wash it and hang it up. You cannot wear it. Put it in a bag. Don't put it in a bag. It was crazy, right? So every day we're telling the staff a different thing. They're all scared that they're going to get COVID, going home to their families. New York, we boarded people in hotels. It was insane. But when we looked at the case log, it was like everybody else, right? We had to create a strategy around classification of what was a category 1, 2, 3, and 4, and that was across the system. So we really made sure that each service line gave us their guidelines on what's a urology category 1 versus a cardiac, and then using that strict criteria and often having that conversation with a surgeon to say, I'm sorry, this does not meet the criteria. We made sure that any patient who was diagnosed with cancer was considered a category 1. We did not want to delay their treatment. But again, we were struck because we had to change our PACU into an ICU. So again, we were great because we immediately stood up a negative pressure PACU out of a space that we were using for pre-op. They were able to vent out the windows, and we were all making do with what we had. But we knew that we had this long list of cases pending, and my one hospital is really 90% ambulatory, and that's where I have the system of LeanTOS that I use. And we had, I think when we stopped and looked, we had over 800 cases pending in our backlog that we had listed in IQ, and we really had to work to determine how do we now that we're starting, once we got the go-ahead to start elective cases, how do we prioritize and get those patients in the door? Because every single patient has been waiting, and you can try and sympathize with that and say, okay, well, but then some of them were even scared to come back. New York got hit really hard, and patients were just afraid. Our surgeons were afraid to come back. So it was really challenging. So then we had to do the same thing. We had to rebuild the criteria now that we were open to say, what's our priority? What has to go now? And then slowly work back. I think for New York, I could speak probably for New Jersey, we're in a lot better shape now. We have a very high vaccination rate in New York. We went on the second surge, we had to go back to swabbing patients pre-op, which we stopped. We were using vaccinations for a very small period of time, but that went away when the second variant hit. But it was really important to make sure that as a system we were doing the same thing, because you can have a surgeon who operates at one facility and then go to another facility, and if we weren't on the same page, we were going to be in bad shape. But I think one of the other things that we struggled with was when we redeployed our staff, a nurse is not a nurse is not a nurse. And I must have said that 100 million times to administration who's sitting behind a desk and doesn't understand. Just because I have an RN title after my name doesn't mean I can go to the bedside. And OR nurses are not bedside trained. So we had to take real quick action to get them to do something, to do a finger stick, do some vitals, do some blood draws, so they can support that nurse who is at the bedside with now a much higher patient ratio. And I think that was a big lesson for me that I took away, that going forward now as things sort of somewhat calm down, hopefully for a while, that we continue to work on that education with the challenge of having no staff. So it's really going to be a challenge going forward.
So regardless of what software any of you are using, be it Cerner, Epic, Meditech, or some other softwares, did you keep track of cancellations? When you talk about financial impact, excuse me, it's always missed opportunity, right?
Yep.
It's the missed opportunity that heart canceled, or that urology case, or that laminectomy, or whatever it was. I know in my hospital where I was at the time in Savannah, we kept pretty accurate records via our software of who canceled and when, and then later on, and I mean much later, although it never left the forefront of our minds, worked with our physician support folks, which we're fortunate enough to have, to reach out to the doc or to the clinic and say, hey, Mrs. Smith, way back here, is she still going to have her surgery done? Can we do that now? We're slowly reopening. Can you talk, Alyssa, about software opportunities?
Absolutely. So as a non-patient care organization, we had the ability to, or opportunity to partner with our customers when you think about the financial aspect, to figure out how do we help them get back to where they need to be quickly, right? And so when you think about capacity management, it's not only from an analytics perspective, but also from a scheduling perspective. So with Cindy, with Northwestern, some others that we partner with, we had the opportunity to say, okay, what is your backlog? And then how do we help you tailor the scheduling process to allow you to either schedule patients now that you need to, or postpone that and get them scheduled at the right time. So certainly part of the software allowed them to quickly act when they could, but also nimbly respond if they needed to by saying, we can't unfortunately serve this bucket of patients right now, but we can schedule them out into the future. So the analytics coupled with the scheduling components really allowed organizations to nimbly respond to what was happening with COVID. The other thing I would say is that we partnered with our organizations that we work with to say what strategy will work for you. So some folks went back to completely first come, first serve. Some folks went back to 50% block schedule.
I was going to ask you about that. Did you recommend, like, if you're 10 rooms that you went down to 3, let's say, I'm just making that up, but did you say we'll come back at 5 or then 7, or is that how?
Yeah, so I think it depended on the organization. I know
Staffing.
Staffing. So there's many factors, but we really did recommend where you could, 50% block and 50% first come, first serve, or fully first come, first serve, because it just allowed the physicians who had been seeing patients in clinic to add them to the schedule. If you didn't, then they would book farther out into the future. Those who did adopt the more flexible model were able to respond much more quickly, getting people back onto the schedule. But as you all know, there's been many waves, right? So that's where the analytics part really helped them, predict and say, here's where we have the ability to modify the schedule and here's where we don't. Even with New York Eye and Ear today, due to staffing issues,
We're still not open all our ORs
Yeah,
because we can't staff them.
Are you fully opened? You are? You are? Anyone not fully opened? I mean, to what pre-COVID, say 2019 capacity? So everybody kind of is, okay.
We're kind of, I think, restricting. Although we're open, I don't know that we're all functioning at the same level we were pre-COVID. And I think that's part of the analytics that I had the benefit of having these lists, right? You talk about patients who were canceled. We were able to pull this list of 700, right? I didn't have the time to physically go through each patient, but I could pull it by surgeon and I could email to them saying, look at this list of your patients. Are they still active? Did they move out of state?
Right,
Did they go
right.
have their surgery somewhere else? And who's left? So let's now work on breaking those down to see who needed to get on the table. And that's how we sort of got through that backlog list. And we had surgeons who left too. They were like, nope, I'm out. New York was really terrible. I don't want to live here anymore. And then you're dealing with that, those patients who still needed care, and how do we get them the care?
Wow, wow. You looked like you were going to say something.
Me?
No, yeah, well, Beth, or either one of you.
Go ahead, Janet.
Oh, so it was, like you were saying, in some of your experience, it was phased as opening. I was very fortunate to have a operations council, which is supported by two chiefs upstairs and a group of phenomenal surgeons, including our traumatologists.
Oh, nice.
And when it came down to, we're going to have to prioritize, and of course cancer was always top on the list, and anything, and again, it's not just any cancer, it was invasive cancer that we had to filter through, and majority of those were really big cases, but also every day, all the directors, and Zoom became very popular, right? Someone said, I wish we got Zoom stock. Well, it's too late. But everything became Zoom, and I would say maybe 3 and sometimes 4 times a day, we would have a director's Zoom conference identifying, okay, Janet, what do you have for the next tomorrow and the next 2 days? And then everyone there, and we had just started our joint program, identifying, okay, what kind of beds are you going to need? But also our surgeons were very engaged and involved in identifying, no, they're booking that as outpatient, but they really are going to need a bed. And that was really key also in identifying who's trying to backdoor, right? Who's sending their patients through the ED just so that they can do their surgeries because they,
Oh, doctors don't do that. They
No,
wouldn't do
never,
that.
never. So
Wouldn't do
those were where we used our surgeon champions also to help us filter through, because it has, for me, it was more important that it became a peer-to-peer conversation rather than a nurse telling, saying to the doctor, because they're more open. Now, with that being said, the relationship that was developed through this whole pandemic became stronger.
Oh, I love that.
Yes, became stronger, very collaborative, and became more of a peer-to-peer conversation than a nurse-to-surgeon conversation, right? So I think that was the biggest takeaway for me, was that the development of the relationship across the board, including the staff level, of having those conversations with their surgeons and saying, Doc, why did you schedule this when you know we have no beds and you knew you were going to admit this patient? Because there's conversations happening in the OR. And again, we're a big teaching facility, so the residents has got to get their experience in, so they've got to do the surgery. So a lot of those were big takeaways, and the development of data analytics, where we were paper before. And then relying on those and validating the data to the surgeons who were data poor, and now we were bringing them data, and then how did you validate it? Yes.
I also want to share that in New York, I don't know about other states, but we were very much regulated by the local governments. We had to give them the outline of what kind of cases we deemed as a category 1, 2, and 3, and 4, and they had input into that, and they were watching us closely to make sure we weren't breaking the rules and doing cases that really were not deemed emergent. We have a large transgender program in our facility, and some people would say that that's considered not an emergency, but then the local leadership in our state deemed that it was emergent because these patients are so psychologically unstable and to delay their cases. So they became a category 1 So you can imagine the conflict, right? I have a surgeon who's like a vascular surgeon saying, well, why do they get to go and do their cases? And you have to really have those in-depth conversations with not only your surgeons, but your staff who just don't understand and want to understand the rationale behind why is this patient allowed to have surgery and who's not. And that was really challenging.
What about just volume drop-offs even now? What are you all seeing? Is your volume back?
Yeah.
No, yes? Yes, ma'am.
Yes, we found what we call suppressed demand. So
Yeah.
in the beginning, people were all scared, but probably this year, we started seeing more of our patients coming back saying, okay, I understood COVID, the surge, the panic, but I'm done, I want my surgery now. And so we're finding more and more patients coming saying they've waited long enough, they've been delayed, whatever, and so they're now sort of demanding more that they not be put off anymore, regardless of additional surgeries. They figure by now we should be able to deal with this on an ongoing basis and move forward.
And what kind of facility do you work?
I work for Kaiser Permanente.
Oh, I was going to guess Kaiser because I know with your patients, or they're called members, right? Yeah, members. No, I love Kaiser. No, my sister works for Kaiser out in LA. She's a OR nurse as well. But I know that they promise certain amount of time, right? From the time you're diagnosed and you need, say, a cataract surgery or something, we're going to get you in before XYZ, right? So now they're saying,
Right, so what we did was during the first wave or surge, we postponed patients, and even right now, patients that we're needing to postpone, we keep them whole so that if they're deductible as we get towards the end of the year, we will keep them whole so that they don't have to pay.
oh,
That's great.
that is great.
They don't have their surgery until January or February of next year because we want to honor our patients to keep them where they were when they needed their surgery.
Right.
So we're finding right now that, like I said, the patients are coming back, our referral rate is up, and our throughput is up. So,
So you have capacity then? You have staffing, you have capacity?
well, we still are faced with staffing issues. We're staffed with anesthesia issues for
Yep.
staffing. And what we're doing to absorb this surplus is we're contracted with community, primarily ASCs, because a lot of our patient volume of surgery is
Is outpatient? Interesting.
That makes a lot of
It's
sense.
very interesting.
And we saw so many patients afraid to go to their primary cares when they were able to and didn't get some care. So when they came to our ORs, for some that may not have been as high risk, became more high risk, especially in our CVORs. I know Lisa's here and her husband's a nurse in cath lab, and I know that in that space they had a lot of really sick patients that were coming through.
Right.
I think that was one of the things that we saw after the first and second surge is that patients were coming in much sicker that, like you said, they could have been outpatient, but because of waiting, and those were some of the things that we did also had to take into consideration when we started leveling and identifying who's going to go first. And we really relied a lot on our surgeons to give us that feedback of who needs to go and who can certainly wait a couple of months.
So Vic, you're the data guy. How do we know what all this cost? You tell us.
Oh, wow.
And if you do, you're going to get the Nobel.
I was hoping
because-
that I don't get asked that, and I was so happy when you started off by saying it'll
We'll
be,
never know.
we will never know, and I was like, yeah,
Well,
that's
I think we will. Now that's my personal feeling, and I am a numbers kind of person, and I don't think we will ever know. I think even if you tracked 2,000 surgeries
Yes.
that were canceled and you got back 1,500 of them, and that's only one element. I don't think you can track the
So-
staffing, the redeployment.
So continuing on with my optimism theme, the next challenge that we are already seeing building up is our supply chain.
Supply chain.
What's on
And
back
it's
order?
not the PPE anymore, but it's a lot of other stuff that is starting to show up as being concerning. Staffing, of course, is a huge issue. For us, the demand is back like nobody's business. We have people coming back really quick, and probably, at least anecdotally, they are sicker.
Yeah.
So all the cancer screenings that were not done are likely coming back at a little more advanced stage. Our ED is full of boarders, and the next thing that we are watching out for is how can we basically keep our regular business going with all of these constraints that are starting to build up now.
And as we do our budgets, right, it's budget season for us.
Yeah.
And they're not even comparing 2020, it's just not even on the map. It's
For volume, you mean to
for
budget the
anything.
volume?
They're like, 2020, that didn't exist. So let's go back to 2019 and then use the last 6 months of 2021 in order to forecast for 2022, knowing that it's a complete guess game, right, on if there's another surge or
Right.
not.
Right,
But really, it's not great data that we're using to forecast our
Agreed.
future.
I think 2019, the end of 2019 and 2020 was such a blip on the radar that no one can accurately have predictive data anymore. I mean, for that. So if you're predicting your volume for next year, you're right.
It's
Well,
it's
your
a-
guessing.
strategy shift, because think about everything that moved to an outpatient.
Correct.
And so if that was a big line of business, do you need to rethink about your strategic agenda and how you're going to grow your volume or sustain what you have in upcoming years, and how does that impact your strategy?
And even capital equipment in 2020,
Oh,
we
yes.
couldn't get it. To your point, Vic, I mean, you couldn't get it. I mean, the anesthesia machines that were built in maybe South Korea or somewhere, I mean, you couldn't get parts, they couldn't get, our vendors couldn't get us certain products that we needed.
But I think,
'Cause,
to that same point, as this young lady talked about, volume that was typically in-house now went to an ASC. You pause and say, well, let's keep it at an ASC. It belongs in an ASC. Do we need more ASC capacity? Let's open another ASC. Let's strategize in the next year about what else can we keep out of the hospital, because it doesn't need to be here, and it allows us to open more ORs for cases that do need to belong. And that's really the future, is ambulatory. But this really gave us that push to say, look, it's true, this is where these cases need to be. They don't need to be here.
Are there any PACU leaders here? Or are you all intra-op kind of people, or directors or managers intra-op? You're PACU? Oh, you have all of them? But how many PACUs are still serving as mini ICUs? Anybody? Because that has happened in many places too, where the
we're past
ICUs
that.
are so crowded that a part of the PACU got shifted into another ICU.
And if I could just
Sure,
add
please.
to that, is that also, the pre-op ASC area became a transitional also, because you didn't just need the ICU. Those that were maybe on the cusp of being discharged, but not quite yet, right? You want to move them to a lesser level of care that's needed so that you can free up that other bed that you need for a little bit higher acuity. So a lot of planning of, okay, what areas can we kind of invade and transition quickly, because putting up a tent wasn't very quick.
Right.
Yeah.
Well, I read an article that hospitals were never meant to be outpatient clinics. We're not set up for it. So now all of a sudden hospitals are putting up tents in their parking lots to either do tests,
Or triage.
vaccinations, or treatments. They're trying to do it outdoors. It's not our bailiwick. They're not set up to be that nimble. I love that word that you used, Elisa. We're not that nimble. So that was a huge shift. We're not CVS or Walgreens. So giving outpatient tests is not what we're good at. And I couldn't agree more, because they talk about, well, we need a tent. Well, where do we get a tent? I mean, that was a big thing.
And who goes in the tent, right? In New York, we had this big ship, right? The big ship that was on the
Oh yeah, and
on the
didn't you use
Hudson.
like a big convention center or
We have
something there?
yes, the Javits was turned into, but they gave us very strict criteria on who they would take. They would only take the somewhat healthy non-COVID. Well, we didn't have any of those. It's like, so the ship was empty, the Javits was empty. And it was like, so yeah, keep telling the public that we have all these resources, but you're not taking our patients. And it took the leadership of the hospitals in New York and New Jersey to go to them and say, we need your help with our COVID patients, not our healthy or somewhat healthy non-COVID patients, because those were few and far between. Those patients were staying home. It was the sick COVID that were filling up our facilities. And we needed that relief to get them out. We still have our tent, even though it's now used for staff meditation and wholeness, and puts TV screens in there to let them decompress, but they don't want to take it down. It's like, let's just leave it there just in case. But it was a challenge, because we did, again, they were like, yeah, we'll send you the resources, but you have to follow these rules. So it was
So,
hard.
and you had said that you're not doing routine COVID tests for surgical patients
Yeah,
now?
we stopped for several weeks in New York. We were able to use your vaccination. If you could prove you were fully vaccinated, you didn't have to get a COVID swab because the numbers were so low in New York. And then as they uptick in this last surge with the new variant, they made us go back to
Oh, so you're
pre.
doing it.
But now they're talking about going back to vaccination only for elective
Well, in New
cases.
Orleans, we still swab every single person.
We're swabbing now,
Everybody.
but-
Everybody gets swabbed for surgery. Is that y'all's experience, or?
And how do you
Anyone?
set up for that process, right? How quick did we have to set up to test all these patients for
Oh my gosh.
for surgery to get their swab and get them back in 3 days and crazy.
So what we found also is those patients that came in through our level 1 trauma recess and through the ED needed to be swabbed also because we were a county hospital, we were a designation, and the other part to that is also as we started developing monoclonal infusion.
Yeah.
Okay, where do you do those? Because no infusion center wants to do monoclonal because these are positive patients.
Right.
So we had to take a little part of our ED as they were coming in symptomatic for and agreed to it. And that's where we actually created our monoclonal infusion
If you
because no one
can
else.
even get it. I mean, in the beginning, when we only had 200 tests a day,
Yeah.
you had to really decide who was even going to get the test. Because that's all the swab sticks you had. That's all the lab could do at that time.
Yeah.
I mean, this is back in 2019. I mean, that was something. Well, why don't we spend the rest of, I don't even know what time it is. How much time do we have?
10:45.
15 more minutes.
10:40.
Oh, we have 15. Oh, perfect. So why don't we spend the last 15 minutes, ask us anything, or let's talk about it. Yes, sir.
Yeah, I find it interesting you were talking about the cruise ship in New York. You know, they actually turned this building into that. They
Really?
Wow.
I'll be going now. I
this building,
didn't know that.
and in total, they saw 3 patients.
Oh my God. See? Yeah.
No way.
Nobody had the right patients to come here.
Yeah. Or the yeah.
How did they staff it? I'm curious.
They asked for volunteers from, around the Chicago area.
Wow.
the retired people,
I
the
didn't know
nurses that had
that.
retired, the doctors, everybody.
My question though is really about the national staffing shortage. And not so much about what you're doing to bring nurses to your hospital, but what are you doing for the nurses that are still with you? We recently did a staff survey, and of course the number one complaint was salary. But after that,
It's always money first, right?
right, and that's a legitimate concern.
Yeah, yeah.
But the other concerns were lack of support and increased stress. So
Yep.
I'm wondering what you all are doing in your organizations to address those issues.
So I can start. I know that there's a huge focus on our nurses and their well-being, mental well-being. So we actually have an app that was created that allows our nurses at any time to be able to go on and speak to someone. And then, we've got, it's been any CNO call that we're on for our organization, that is always the top concern is, we've got to take care of our patients, but we've got to take care of our nurses. So there's been an incredible amount of focus put on the well-being of our nurses. We've had some facilities do the retreats in the facility like you spoke of, but I love that a nurse at the end of the day can go online and talk to someone if they need to, and it's a safe place for them to decompress or to get what they need.
I couldn't agree, Beth and I work for the same company, and I couldn't agree with that more. But sometimes I think, to your point, we forget to ask them what they want.
Yeah.
What do you think is supportive? Because we do what we think. It's almost like being a parent. You do what you think is right, but what do you actually think is important? Yes, ma'am. The app is great.
I don't know the answer to that. I don't know how many of our nurses are using that. I'm sure we are an extremely data-driven company.
I'm sure we do know.
I'm sure that someone can tell you exactly those numbers. Our VP of the service line is here. She may know those numbers, but
Do you
I
know
do
that,
not.
Stephanie?
I don't know the numbers, I know it has been well received, and that it does get usage.
Yeah.
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 I think that's such a great thing to share, when you can show those success rates and show others, like, if you have, because that's the
I can tell you from a personal viewpoint. I'm working with Tulane University right now, which is in New Orleans, and as I'm sure you know, they just recently experienced another Cat 4 hurricane, Ida. So I went down there as soon as possible after the hurricane, and when I say as soon as possible, because there is nowhere to stay. I mean, other than sleeping on a stretcher in the hospital, which I'm fine without. We've all done that probably time to time, so because it was a total power blackout in the French Quarter and all of New Orleans, and Tulane sits right down in the business district of New Orleans. It's a very big hospital and university setting. Anyway, our company flew in generators at their expense to a Marriott hotel, powered the entire hotel, put every healthcare worker from Tulane who needed a place to stay, because many lost their homes, still have lost their homes, totally destroyed. Hundreds and hundreds of us in that hotel for free, for us, fed us 3 meals a day. All 3 meals were catered, and I don't mean a cheeseburger in a box. It was like steak and mashed potatoes. it was a good thing from a restaurant, and then shuttled us to work and back every day for about 6 weeks. Now, hopefully our employee survey, which we're about to do, frankly, will reflect, I hope people will see how much the company did try to support their team and keep the hospital afloat and working during the hurricane, which was so sorely needed, and COVID on top of that. It was a double whammy. But I think when companies do things like that, and I heard from my sister at Kaiser what they did for their nurses out in California, and I know we started right off the bat. We paid our staff when they stayed home. They still got paid. They didn't have to use their paid time off.
Yeah. I think one of the things we're struggling with in regards to what you're talking about, right? We took the initiative to do an employee engagement survey right at the end of the first surge, knowing that it was a time where staff was still raw. They were still recovering from this, what we went through, but we really wanted to hear what was important to them and asking those critical questions, right? But we're also dealing with travelers. So many nurses have left to go to travel because they're getting paid an enormous amount of money. So you have a staff member who's worked tirelessly through this pandemic to have a traveler walk in the door and make twice as much money than they do an hour, and how do we compete with that? Plus we're in a union environment, so we can't just up the salary of our existing staff, but yet we have to give them whatever we can to make them feel as valued as the traveler who's just walked in the door.
I think that's the key, is feel valued.
And then on top of that, let's put the vaccine mandate out there, right? Everybody who's felt like they were here and now we're zero, we hear that all the time. You're forcing me, why do I have to have this? I've worked all through COVID without a vaccine. So that's really weighing on the staff now that they've survived the pandemic. Now we're throwing all this other regulatory stuff at them. So it's really important. And I think from my organization, the senior leadership team, we've taken the approach of boots on the ground. We are rounding all the time, all shifts, weekends, nights, and just going up there and just, we pick a topic of the day, but it's more like, how are you doing? What do you need today? What are you struggling with? What can I get for you? And offering a lot of wellness, meditation, any outlet, any conferences that they want to go to on wellness, supporting that. But it's a really hard ask, and we're just getting the data from our survey, and we're like bracing ourselves for what we're going to hear. But it's really
It'll be honest, though.
Yeah, it will be, and that's what we need to hear, because that's really going to help us in the next year focus on what's important to our staff.
Well, and as thousands, millions of Gallup surveys have told us in past years, people don't leave institutions, they leave managers.
Yeah.
I mean, that's a key takeaway from almost any survey. They leave managers. They don't, their direct supervisor is going to keep them or make them leave. But
So I'll just add that I think there is obviously a short-term solution that we are all seeking because we've got to take care of the next week's patients and the week after that. But I think this is a bigger structural issue that needs to be solved long-term.
Yes.
Otherwise, we will just keep trying to put bandage on an issue which is much bigger than that. And that, I think, I don't know what it is, but maybe more nursing schools, preparing, having a more, so I'm obviously not a nurse, but I interact enough in the peri-op to understand that all nursing would like to see a very structured ladder through which they can keep rising and be recognized for that work. And I don't know how well a lot of our organizations are able to do that.
That's a good point.
And they start young, they probably don't know enough about a lot of the managerial administrative aspects. So are we giving them opportunities to keep learning and growing and acknowledging the ones that are going above and beyond each day and doing that work? And so I think that long-term thinking has to come. And then being in an academic medical center, we know how physician-heavy specific we are likely, and amongst in that environment, how do we put the nursing at the same pedestal as we probably put other healthcare providers? And so I think a lot of bigger structural issues for long-term to be solved.
Yeah, that's a really good point.
Especially as we look at the financial impact, right? We can imagine the money we lost during COVID, but it's the past, right? So what are we going to do with our money going forward? How are we going to invest in our staff? Our School of Nursing just decided that they would take any associate's degree nurse, which normally we don't hire. We're a magnet, you have to have a BSN, but bringing them into our School of Nursing and guaranteeing them a job at the end so that we can nurture them and bring them back and get them into the field at an opportunity that they may not have had before. And just to, again, invest in them and to let them know that we value them and that we want to build more nurses. We need more nurses.
And I think we're all.
Hi, everyone. We're back here live. Thank you to everyone for joining us here. We're going to dive right into questions. We've got Sherry Church and Beth Bozelli and Vic Tawari here with us to answer your questions coming off of the session from Chicago. So with that, I'm just going to go dive right into some of our questions that we've got from the audience here. And so I'll direct this first one to you, Beth. You had mentioned at the beginning of the session that staffing was a big problem that your organization had faced since the pandemic. And so how do you see staffing issues playing out as we head into 2022?
Well, I think that we have to rethink how we staffed historically. I mean, we still have to have a nurse, we still have to have a tech, we still have to have assistants, but what does our staffing pattern look like in regards to our prime time hours? I think that we need to think about how we can use our pre and post nurses and cross-train them in those areas. I think we need to think about our nursing schools and really partner with them. I recently read a study where our NCLEX passing rate was down. And when we think about trying to finish nursing school virtually, I can see how taking your NCLEX would be difficult. I know that in our organization, we're partnering with nursing schools and also looking at how we can do that with techs to support. But we have a lot of people. I recently spoke at a director development program, and it was 8 strong OR managers that want to learn to be an OR director. And every one of those in that class, this was their second career. They had been something else. I think we're seeing that a lot as we see a lot of our OR staff retire or go into a different career. We've got a lot of people doing this as a second career. I don't know that we know how all this is going to play out. I mean, our staffing shortage is not only due to the pandemic, it's nationwide. Mm-hmm. Sherry, you may know more being in the field.
Oh, I think she's on mute.
Yeah, you're on mute.
I'm sorry. I didn't want you to hear my oven go off or something. Okay. So, listening to the panel today, and Vic, something you said really stuck with me. Maybe I was too nervous before to catch it, but you said something about having a structure that a nurse can promote himself or herself within the structure, and I think that's very spotty today. I think, in my 40-some years, some places have the clinical ladders. That's the traditional name, or some kind of a bonus program if you do a project or something like that. that said, I've really seen in the latest years, nurses want to do something, they don't want to come into a job that's going to be, quote, a dead end. That either I have to become a leader, which I don't really want to do, or I have to go become an NP, which I really don't want to do. But they want to be the best subject matter expert, the best whatever. So they really need some sort of structure, and maybe that would make it a little bit more of an exciting career to know that there's growth, that it's not, you're not just going to get a 2 or 3% raise every day or every year. You have a way to grow. What are your thoughts?
Yeah, absolutely. And I think what I realized, because I have management training, right? And I also teach in the MBA program. So I see how we are training the MBA students, right? We are forcing them to ingrain them with leadership qualities, right? But on the other side, when we have our frontline people, we are telling them to be working 8 hours, 9 hours. There is no scope, there is no flexibility or that little bit of leeway to be able to expand and think about something else. And that's where I think that structure, if unfortunately the way our things, and Beth was referring to that, the staffing shortages is causing more of this problem, right? That we have no choice but to request our nurses to work overtimes on weekends. And so that's what I said, this is kind of a long-term structural issue that needs to be fixed in some manner so that we have people in healthcare 10 years from now also.
So bottom line, we need to make it more attractive. Right. And it isn't just about the money. I mean, we know right now people are killing themselves for, $1 million a week. I just saw an advertisement somewhere in Pennsylvania that's paying $150 an hour for an ICU nurse, $150 an hour. Now, I'm not saying we're not worth it. We probably are. But that said, that won't last forever. And that's not going to solve the problem. The problem is making it a job people actually want, not driven just by the payroll.
Absolutely.
I don't know. Do you think so too, Beth? Or
I do. I think what you said is spot on. Not everybody wants to be the boss, and that's okay. We don't need a bunch of bosses, but we do have to make it attractive. I think that, in the old days, when I circulated every day, I could do all service lines. Well, heck, they're so complex now, and the equipment is so complex. It's hard to be really competent and proficient in 7 different service lines. And so I think we've got to make it attractive and make them feel challenged, and make them feel like they have the tools and the resources to be able to do what they need to do.
Yeah, I do too. I think we have to make the job more attractive. Now that's a very small sentence for a huge undertaking, but that's what I see anyway. That's why kids are leaving. They just as soon go do something else as work this hard, like you said, Vic.
Right. I mean, I know so many even healthcare providers who probably just want to open their own startup. Mm-hmm. And the charm of the Silicon Valley and the attractiveness of developing a company and then selling it off to a bigger company, because they have that expertise. So not that they don't want to be in healthcare, but their options there are so many options emerging within industries and the way the technology is evolving that we should find ways to keep the nursing also just as attractive for those people. With these various dimensions in which their career can grow into.
Right. No, agreed. Carrie, do we have any other questions posted?
Yeah, maybe coming off the staffing issues, one of the questions was, COVID ripple effects. What are you seeing about staffing issues due to lack of daycare?
I do hear that. I do hear that because it changed the way parents take care of their children. The daycares closed and are still closed in many towns. So either the dad is staying home or the mom is staying home, and that's changed shifts, that's changed jobs. But I hear that all the time now. Things I didn't use. You always heard some of it, but not like today, where the full 8. I can't do a 12-hour or 10 or an 8-hour shift because my 4-year-old has nowhere to go. I don't know. I'm sorry, Beth. Go ahead.
No, I was going to say, and I think some of it has been where we can get into that strategic staffing. So trying to be
creative with our staffing, where we're not doing tens or we're tagging. I
Right.
think a lot of organizations have went to remote, so I think that's helped some of it out. I know in my family, my husband works from home, so when our grandkids have the COVID shut down daycares, they come to our house and spend the day with my husband. So I think that,
Yeah.
it definitely has impacted.
Well, it's just another way that this pandemic has changed our lives. And I think as people, well, we didn't know as much about the 1918 pandemic because we didn't have social media. We didn't have the kind of recording that we have today. But I think our grandchildren and great grandchildren will be reading about this and the ripple effects for decades to come, because we just don't know.
Another ripple effect that I've been reading in our newspapers, Wall Street and others, is what they're calling the Great Resignation.
Yes.
2 million to 4 million people might have just left the workforce forever, and across all age groups. So yeah, the ripple effects are still coming. And I think I go back to what Sherry, you mentioned right off the bat at the start of the session in Chicago, right? This will take a long time for us to figure out completely of what all it caused and the social changes it has led to. And the working style, right? I'm sitting at my home. I'll go to the office after that. Just I wanted to do this from here.
Oh, I'm sitting in my home today too. I'm sitting in as you can see behind me. Beth, are you in the office today?
I am in the office today.
Oh, yay!
Yay.
But yeah, it really has changed so many things, and those ripple effects will be with us again for decades and decades. We're never going to know exactly. Someone somewhere, some economist will put a number on it, I'm sure, but who knows? Us that lived it, we're going to say, "Is that be right?"
Well, and Sherry, when you talked about reading in the history books from now on, one of my grandchildren, I don't know, I'm talking about my grandson here today, actually said, "You were born in the 1900s." I'm like, that was not that very far ago. Yes, I was born in the 1900s. So.
Oh my gosh, that's so funny. Yeah, we're old. We're old people. What other questions do we have, Carrie?
Yeah, so playing off the ripple effects or looking back and when everything started happening, Vic, one of the things that struck me was when you had said, you mentioned analytics going out the window and the question of how many ORs should we retain for normal business? And, how did plans evolve? Like what defined an elective surgery? How did you guys rationalize that?
Yeah. Right. So I'll probably rephrase it. I don't mean to say analytics was thrown out or was not useful, but our traditional reports and our traditional metrics were suddenly not something that we can just bank on. And we had to quickly develop these new ways of thinking. And one of which, of course, was what is an elective surgery? Because in the first phase, right, we all elective surgeries will go. But we realized that not everything is elective, and most of our business, in fact, is not really elective. So the definition we came up with, we call them the can't wait surgeries. And we said anything that typically gets booked within 14 days from the day of surgery is a can't wait surgery. And it included what sometimes we would at least schedule them as elective cases, but they are really can't wait surgeries. And so that was the cohort that we decided will keep coming. And based on that, we decided how many ORs and which ORs we must retain for this business. And based on that, we decided how much capacity to reserve in ICU and the floors for these surgical patients. And obviously, we didn't need all of that. However, as things progressed, we also realized that the surgeons, and I think our other members were speaking about that also in the discussion, the surgeons are the best people to know which surgeries really need to be prioritized and which patients they have to prioritize. And the other challenge was when you don't have enough staffing and you don't have enough ORs that you can run, then if you have a lot of high priority surgeries, then within that high priorities, how do you prioritize that?
Mm-hmm.
So
yeah, we I know at HCA we deployed and used what was referred to as the Stanford model, which came out of Stanford, and it had a if-then kind of scenario. If it's this, then that. If it's this and that. Also, we put our heads together every day with the CMO, the chief medical officer at the hospital, who would review the proposed schedule and say what could go and what couldn't go. But another ripple effect of all that is these surgeons, they're losing money too. They're not working, because if they're not operating, they're not working. And they all had practices. They all have people on their payrolls. They all, these are working men and women. So that many, I'm sure every hospital in this, of everyone in this audience, or had some eager beaver who would come and work every day no matter what, because COVID be darned, they were gonna work anyway. It didn't have to be a impending cancer diagnosis or something like that. So we had to talk through that every day about why Dr. Smith couldn't do his PE tube or whatever it happened to be. But that was definitely a struggle. Not as much now, to be honest. In what I see now more is the lack of post-op beds. It's not surgical capacity as the lack of post-op beds.
Right.
Yeah, and you can't reserve. You can't reserve those beds because you're vying for them from the ED.
From the ED, right. Yeah. Exactly right. But a lot of PACUs are still mini ICUs right now, at least in our facilities. We have a lot of PACUs who hold ICU patients overnight.
Yeah.
In some cases, and I imagine in the audience as well.
We have another question that came in, going back again to staffing and new regulations that have recently been passed concerning vaccinations. What are you seeing within your institutions regarding staffing concerning the vaccine?
If you want to go with that for HCA?
No.
At Vanderbilt, Vic, is there a requirement?
Yeah. I mean, we can people can seek exceptions, but I think we are at 99% vaccination.
That's really great.
And ours has not went into effect yet, and so we're just now having those conversations with the facility and with the staff. And of course, same Vic as Vanderbilt, there's exceptions based on different criteria. So we haven't. I'm not sure what that outcome will be at, or what percentage of our nurses are already vaccinated. So.
Right. We have, I think, a January 4th target date that all of our team members must be vaccinated. And we'll lose some. There's no doubt. I mean, you're going to lose some people that won't be vaccinated, but it's become a job requirement, just like TB, just like a flu shot, just like the other things that we've all had to have to get into school. And it's just a job requirement.
Right.
So we'll see how it plays out over the next year, I guess.
Yep. Especially
and I wonder, since it's, sorry, Vic, I wonder since it's, I think we've already had some health organizations that have already done that, and it's been easy for nurses to hop from hospital A to hospital D because it's a different institution. And I just wonder what the impact's going to be since it's across the board. If they want to stay in nursing, they may not have another option.
That's a good point, Beth. There'll be nowhere to go.
Yeah.
There'll be nowhere to go. So yeah, nowhere to go. What other questions do we have, Carrie?
Well, Sherry, you had mentioned earlier on, at the beginning of your session that you've seen a lot of viruses over your career and the panic that you and your staff face.
Right.
When COVID hit, how did you rationalize in your mind how that was going to play out? How did that compare to, say, when hepatitis was the big scare?
Sure. Well, we're lucky in the OR in a sense because we've always worn protective equipment our entire careers. And I'm talking intraoperative. We've always been, no, I'm going to take that back. We've not always been careful. but we should have been careful. When hepatitis was a big scare, when AIDS came out, it was a big scare. When the bird flu came out, it was a big scare. I can remember as a young nurse in the 70s in the operating room, not wearing gloves all the time. Not putting on gloves and picking up a bloody lap off the floor, or we didn't wear gloves to start IVs. We didn't, we weren't as knowledgeable, or maybe we were academically, but it hadn't gotten to our practice at that time. So when we first heard about COVID, our first reaction, and I was working in a large hospital in Savannah, 26 operating rooms, and our biggest thing was, well, what do we do now? We knew that it had to be a negative pressure room, not positive pressure room. Most of us don't have negative, because it's airborne. Most of us don't have negative pressure except in a pulmonary unit or a bronchoscopy unit, or some endoscopy or in bronchoscopy. So how do you turn a room into a negative pressure room for the best results? And then, and literature kept coming out, one thing after another thing. Is the anesthesia machine clean? Do we have to throw it in the trash? I mean, we just didn't know. Could the droplets come down and contaminate outer packages? All that kind of thing. Should we have a runner outside the door so the team inside never has to leave? The runner can go get whatever anybody would need. So we just worked through that. And as I'm sure all the nurses in the audience today, we just worked through that. Every day we took the best information. I don't think we were, to be quite frank, where I was, I don't think anyone was really terrified within the operating room, because we already did suit up. We already had the hoods and the breathing systems. What am I trying to think of? The striker hoods, those kind of things. We already had that. So we just dressed accordingly and we're cautious. But I don't think we didn't have anyone say, no, I'm not going to go in there, or no, I'm not going to do that. We really didn't have that within intra-op.
Mm-hmm. I think one thing that probably all of us, including people in the audience who may be listening, is I think we should institutionalize, for each of our institutions, we should document how things progressed and what we did. Because this will not be the last time, and we may not be here 20 years later, maybe another one comes. The way we had to scramble, because none of the people had seen anything like this before. And so if we institutionalize this as a learning organization, we shouldn't have to keep reinventing it. We should have kind of a charter, a roadmap of what could happen. All those protocols that we were developing on testing, should we be testing, should we not be testing, how often, who gets tested, who doesn't get tested. So that knowledge we should somehow document, and hopefully somebody will publish that so that others can also learn and share what worked well for others. And because it was very painful for almost all of us to just have to do playing catch up with what should we be doing. Is there a CDC protocol guideline for this? Or let's ask somebody. We are calling our colleagues to figure out what's going on at their institution.
Dick, I nominate you. You start a committee. No, I think you're spot on. With that, and hopefully that is going to happen, or is happening. You're exactly right. Now, will our future selves pay attention? I mean, will we pay attention? Will we say, okay, that's what we ought to do? That's what, let's hope. But I agree, the documents need to be there. What we did. I know the OR became a supply resource. Everyone in the hospital ran down and listen to me, help themselves, masks and gowns and the hooded system. I mean, everybody wanted those. So that, of course, immediately led to a big supply chain backup and stoppage. And
OR also became a source for labor. I think people realize that the most trained people likely in the hospital are the OR staff, including our anesthesiologists, our CRNA folks, our student nurses. I mean, they were going all over the place in the hospital and helping out.
It's true. But and on that point, that probably created more panic because as an OR nurse myself of decades, I would be terrified to take care of a ICU patient, not for COVID reasons, but because I simply don't know. I haven't worked with meds, haven't, so that was hard too, is letting our leadership know, our executive leadership know, a nurse is not a nurse, it's not a nurse. I mean, they don't have trained out. Can they run? Can they fetch? Can they take vital signs, work as an aide or a tech? Absolutely, and we did. We all did that. But you're right too, and Beth, you mentioned that earlier. We become so specialized that it's hard to interchange on a moment's notice.
Well, that brings up a good question. Change and shifting on a dime. At the beginning of your session, you had talked about what the last 18 months were like and describing and the memes of what it's felt like. And that was great examples of how I'm sure it's felt for all of you and people in their personal lives too. So if you had a crystal ball, and this is for the whole panel, looking ahead, what do you predict might be the next disruptor? What might that meme look like in 2022 and beyond?
I'm going to say it's going to be supply chain related. I don't know what the meme would look like, but I'm going to say it's supply chain or staffing related.
Yeah, I was going to say staffing. I think staffing right now across our hospital, not just peri-op, but the whole hospital.
Yeah.
If we don't somehow make it more attractive, and I don't just mean by money, of course, money helps. I'm not, in a cave. I know that helps, but that's not all of it. That's a part of it. But we have to make the job more attractive. And I love what Vic said earlier about that. We talked about.
I agree. Yeah, staffing continues to be a challenge across the hospital, across support services also. So it'll be an interesting year ahead for sure.
Yeah, I think that's going to be the big one. And what is the average OR nurse today? Aaron puts that out. It used to be 48. It may be even older now. The average OR nurse. Hopefully, our nursing schools will bring students back to the ORs, which they haven't done in decades. They may get a day, but they don't get to see it. So we'll see. We'll see, but that's what Yeah,
is there anything that your facilities are doing to encourage nurses to pursue a career in nursing, like at the high school level or in university?
Good question.
Yeah, for us, it's at a local level, but we have a lot of our local markets go and speak at schools, do career fairs, work with high achievers in their facility that may work in dietary or in another service and support them as they go to tech school. So we're trying to get creative. It's a challenge because everybody's fighting for the same staff.
Yeah, it is a challenge. Yeah, we used to do health fairs and things like that, Carrie, but then with COVID, of course, that all ceased. Yeah. Going even into elementary schools and doing just heights and weights, but just showing the kids, like in a scrub outfit that, we're nice people. Don't be afraid when you go to the hospital. You remember the teddy bear clinics and those kind of things. Our local hospital, my home hospital, has done for years, but COVID kind of stopped that. But to your point, yeah, I think there's got to be more conversation at nursing, in college and colleges with nursing schools to encourage young men and women to take it up.
That's great to hear, and hopefully we'll see more traction on that now that we're moving forward and crossing the finish line here. Hopefully, we're getting some towards the end of our hour. We've got some comments that this has hands down been a really relatable discussion among peers. So the audience is really appreciating. We appreciate you all for taking time to meet with us. And I would like to thank you for your time and thank the audience for joining us virtually. And we hope you'll be back online tomorrow for our virtual sessions that begin in the morning. And we'll have a PDF handout of the slides that were available. We'll make those available in the platform that you're watching this program. So with that, I would like to thank our panel once again, and thank you to our audience for joining us today.
Carrie,
Thank you, everyone.
Hello.
Hello. Oh, did Vic?
Oh, did Vic jump off?
Vic was done.
He's like,